Good morning. The last day we were here, the program ended with a demonstration of rotatory nystagmus, and a couple of students volunteered. After the class was over, another student appeared whose nystagmus is of really a different order of magnitude, and I asked him to come this morning so that we could see the same experiment on him, and I think you'll be glad to take a few minutes for the rest of the demonstration to watch him. The student is Phil Corbin, and he shows a certain amount of nystagmus at rest. This is one of the interesting rarities of neurology. As far as we know, there is no pathology. It is probably congenital. I never asked him, but is there any one in your family who shows it?
I don't think so.
So it is one of those total rarities. It doesn't bother him. He knows he has it, but there it is. Now perhaps you can focus the other camera down on his eyes and let us see them. All right. Particularly his left eye. Let's look at this now closely for a minute. Take the little card away from the monitor, because I like to watch the monitor too, and you can see the normal resting, not normal, but the resting nystagmus that is here. It is of two kinds, quite fine and quick, as you see now, and then at times there. Did you see the quite extensive nystagmus as he turned his eye toward one side? Just for a few flashes, there was some really extensive nystagmus. Here then is a person who has a certain amount of nystagmus as he is normally. Now let us give him the rotatory test and see how this accentuates the condition. We'll ask Mr. Moore to come and help me turn Phil. He'll take his position, hang on tight. We will slowly turn him to the right, this way, to his right, 10 times, about a second for a rotation. We will stop him on the count of 10, and he will look at the camera. Now, you'll recognize that when we start to turn him, the reflex begins, and the nystagmus will be produced, tending toward restoring his fixation. We can't see that when we rotate him, so we will take advantage of the fact that the endolymph has inertia, and when we stop him suddenly, the endolymph keeps on going. So if he is turning toward his right, when we stop him, the endolymph will keep on going to the right and give the impression in his reflex centers that he is turning to the left. So we will see the post-rotatory nystagmus, but it is an indication to us of the presence of the nystagmus during rotation. Now let us just slowly and gently turn him. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Camera. Now you see, very strong, persistent post-rotatory nystagmus. That, I think, is the best demonstration any student anywhere will ever see, truly. Maybe that's going a little far, but now we might have seen more if we had just got him looking at the camera a little more quickly. Phil, do you feel all right?
Yeah.
Would you try it once more?
Let's go.
All right. That's the first job for any physician or surgeon, to gain the confidence of the patient. Here then is a cat. You'll note that it has all the same attributes of posture that we had mentioned. It holds a particular cat-like position. It can balance. It can right itself. Turns around. If I let it fall upside down, let me see. Will it turn and fall on its feet from this little height? Yes, no problem at all. So it has the ability of righting. It has some other interesting abilities. Let me see if I can do this. Let me bring its forelimbs down against the edge of the table. See? When I do that, you see how it stretches forward its feet and gets on the table. Let me get off to the edge of the table. There. See? Now let's try that again. As soon as the feet touch the edge of the table, they're placed. This is the placing reaction. See? There. So the cat, then, is one of the interesting subjects that we can use for study, and in fact has been the major subject of study of this problem. Way back at the beginning of the 19th century, and you recall that this happened in the frog too, that after the brain was removed, the frog continued to breathe. So too in the cat. If the brain is removed at some level above the medulla, the animal will keep on breathing. Once this was done, and, quote, decerebrate cats were being prepared, then it was found that such animals could also stand and show some of the attributes of posture. Once this began to be studied, it became clear that the standing of a decerebrate cat was reflex in nature, because when the dorsal roots were cut so that afferent impulses could not get to the central nervous system from the limbs, then the limbs lost their posture and the animal could not stand. Therefore, standing is a reflex. Second, the reflex originates in the muscles themselves. The limbs can be skinned or denervated. The animal will still stand. So the reflex originates in the muscle. It originates in those muscles that counteract the force of gravity. So we can say that this is an anti-gravity reflex produced by the stretch of muscle. And if you play with those words, stretching muscles, then you turn that into the myotatic reflex. So the stretch reflex, the myotatic reflex, both names refer to the ability of a muscle to contract reflexly when it is stretched. Now the first graphic will show this diagrammatically so you can get an idea of how it works. Here it is. Here is a muscle with its tendon and the insertion. Here are ordinary muscle fibers, but here is a modified muscle fiber that has, to be sure, muscle in it, particularly at the ends. It is innervated by a motor nerve, and you see the arrow points the root of the impulses. These are small-sized motor fibers that have the name the gamma efferent fibers. They're simply the motor fibers to this particular muscle. This muscle is modified, however, to become largely a sensory system by virtue of the presence of a capsule called the muscle spindle, and you see it's spindle shaped, that's why it's called the muscle spindle, that has nerve endings that are sensitive to stretch. So that, if we can see the next slide, when the muscle is stretched, the muscle spindle is stimulated. That causes the other muscle fibers to contract. The contraction relieves the tension on the muscle spindle. Will somebody hold this cat for a minute? The cat wanted to get it back in the picture, and that's what caused everything to go out of focus. This relieves the muscle spindle from tension, and its firing stops. The muscle tends to relax, and this then adjusts itself out so that by means of this little regulatory mechanism, by the fact that the muscle spindle stops to contract when tension goes off it, the muscle contracts just enough to keep tension on that joint and permit the animal to stand. Here is a complete diagram of this mechanism. Here is the motor neuron that causes the muscle to contract. Here is the afferent fiber, and this afferent fiber comes to end around the motor neuron. The stretch reflex, or the positive myotatic reflex, as we can call it now, is a monosynaptic reflex. It takes only two neurons, the afferent neuron and the efferent neuron. Here then is the reflex that we're dealing with. But all reflexes are now regulated by higher centers in the brain stem and in the brain. And here is a shadow diagram, you might say, of the regulator centers in the cat. Here is the spinal cord, here is the medulla, here is the pons, hypothalamus, the caudate nucleus, the cortex, and here is the cerebellum. There are two general centers here. This large center in cross-hatched black is the facilitatory center. When this center sends impulses downstream into the spinal cord, it facilitates all sorts of reflexes, and particular the positive myotatic reflex. It also accelerates and increases the action of the gamma efferent system, so that the stretch reflex is facilitated at its reflex center, but it is also facilitated by the faster firing of gamma afferents, which put tension on the muscle spindle. This system is opposed by a suppressor system, which also sends impulses downstream. And the reason we stand normally in most circumstances is that these two systems, the facilitatory system and the suppressor system, are in balance, both being slightly active, but each balancing the other. Now, the facilitatory center is self-acting. It is part of a primitive motor center. And indeed, if we leave all of this center in, the animal will walk. And this we will see next time. If the lower part is left in, we will still have facilitation of our reflexes. On the other hand, the suppressor system is largely dependent on afferents. Afferents that come from the cerebellum, afferents which are not shown here, which come from the hypothalamus, afferents from the basal ganglia, and afferents from the cortex. Now, if we make our transection right here, and this is a natural place just between the superior and inferior colliculi, and actually in the cat, following the line of the tentorium cerebelli, the tentorium that separates the anterior from the posterior spaces, separates in effect the cerebral cortex from the cerebellum. Cerebellum here, the cerebral cortex here. If we make a transection here, we largely deafferent the suppressor system, leaving the posterior part, the static facilitatory system, quite intact. Therefore, there is a preponderance of facilitation simply because there is a deficiency of suppression. Therefore, the animal's reflexes, particularly the stretch reflexes, are overactive. And if we do our surgery well, and if the animal survives properly, produces a condition that you know of as a decerebrate rigidity. The animal will breathe. It cannot right itself. It does not show equilibrium. It cannot regulate its body temperature. But it shows the beginning of posture because it can stand, or it should stand if we are successful in our decortication. So today our task is to decorticate the animal by a transection at this level. The next day we will today we will decerebrate, next day we will decorticate, leaving in this area of the hypothalamus and basal ganglia. Now this requires a little discussion, and let us go to the board and list what we must do. First, we must anesthetize the animal. We must anesthetize the animal with a volatile anesthesia that the animal can blow off, because if we anesthetized it with a fixed anesthesia, then the central nervous system would be anesthetized and it could not show the responses that we expect. We will therefore use ether. For our purposes, we will simply hold the cat by brute force and pour plenty of ether on a cloth over its face. We will watch for two things. One, and the most important, is the persistence of breathing. By and large, as long as the animal is breathing, we are safe and cannot over-anesthetize the animal. Two, we will watch for motor tone. Once the animal is fully anesthetized, it will relax and be limp, and we can go on with our operation. Two, we must tie off or occlude the large arteries that go to the brain, otherwise the animal will bleed excessively in the operation. So we will tie the carotids. We will occlude the vertebrals by mechanical force pinching at the back of the neck where the vertebrals are for a brief period exposed to external pressure. We will put in a tracheal cannula so that it will not swallow its tongue and or choke up with secretion. Now I can also show on the board what we will do. Here are the two carotids. We will tie them here. We will put in a tracheal cannula about at this point, tie it in place so here it can breathe in and out through here. Then we will turn the animal around, belly down, and I do not know if I can draw a good cat. Here I put a couple of teeth to remind us that we better be careful. If you can believe that's a cat's head, I can hardly do it. We will expose the calvarium, the bony skull. We will make a hole with a trephine. We will enlarge that and uncover almost the whole of the left cerebral hemisphere, and we will then make the transection and take out the brain. Before we do that, let's look at our instruments to be sure that everything is ready. Here is our ether, some cotton wool to absorb blood, some wax to seal off the edges of bone, a little cone for ether, a knife, a scissors, some ligatures, 2 for the carotids, 1 for the trachea, a tracheal cannula, a trephine, and this is one of the most ancient of surgical instruments known to the Romans and the Greeks. It is nothing more than a circular saw. What camera would like to look at this? Shall I come closer? There. There. See, it's nothing but a cylindrical saw, so that if I put it against a bone and rotate it, I will cut out a little bone, a bony button. This, of course, is the way all surgeons get into the brain. And here is a rongeurs. There it is. This gets its name from a rodent, which is a rongeur. So this is a biter or nibbler. It is then an instrument by which we can eat away the bone and expose the brain. I think now we are ready to take our courage in our hands and do this operation. We will change the position of the table a little bit so that you can get a good view of things. Here, Mr. Arnold Moore will help me. Here is our towel to anesthetize. Here is the ether ready. No, we won't use that. Now this demands a little mutual trust, because Mr. Moore is going to hold the legs and I'm going to hold the head. If I let go, Mr. Moore gets bit. If he lets go, I'll get scratched. We both hang on, or we both let go at the same time. Now, let's go. Mr. Moore now has got the cat. Get your hands up above the joint there. All right. You see that the cat's tail is quite active. Mr. Moore will take that tail in his hand, because at some stage of the anesthesia, the cat usually relaxes his sphincters and micturates, and if that tail is whirling around, this has much the same effect as throwing an egg in the electric fan. We'll watch that. If the animal struggles, Mr. Moore will stretch it tight, and that he has done. The cat will play possum, no doubt about that. We will, however, be patient. I note the cat has not been clipped, so I'll have to clip it before I do my surgery. I can do that with a scissors, remembering that all surgeons were once upon a time barbers, or if our technical staff can run and get an electric clipper, that'll do too. Now, this animal is still very light. Do you see the eye? Ah, somebody is looking at the eye very good. And I can, you see? Shows a good corneal reflex. And it was playing possum a bit because it started to move. Give it a little more anesthesia. One of the things that we must be careful about is losing our courage and panicking. And if the animal gets active, quickly to pour a lot of ether on. Because at this stage, the animal has lost many of its protective reflexes and would take a big lungful of ether and might get over-anesthetized. But at a certain stage, which is coming along now, this animal should begin to relax. The main thing for us to look at is breathing. And here you can see the breathing best. You can also hear sometimes a particular sighing breathing that indicates that the animal is asleep. Arno, are you going to be willing to let go? Just let go for a minute. Take your hand away. He's ready to grab again, and I don't blame him. But you see, the animal is now anesthetized. It is breathing. Here, it's time now to do some clipping. As I say, surgeons were barbers at the beginning of their careers, so it is not beneath our dignity to clip the hair. The animal is getting light. I can see that it is beginning to awaken a little. But that takes care of that. I will turn it around, getting rid of the hair, giving it a little more anesthesia while I clip. While I clip the animal, you see, we took hold of this animal just in time to prevent its getting up and walking off. So a little more anesthesia is the order of the day. Now I hear that the mechanical clipper is turned on. Let's see if it can do any better. Not much. In fact, I think I did just about as well. In fact, I'm sure of it. Let's try another clipper. Ah, that's a good one. the right carotid somewhere. There it is. After one has worked on dogs so long, one is surprised at how truly small these vessels are, and one should be very careful not to include the vagus nerve in the ligature, and that's causing me a little trouble here. Now, this proved a little too long. We must give a touch of anesthesia. Well, I think we're all right. There. Now I know I have tied that carotid. The animal is quite well anesthetized by now, and in fact, its carotids show that it is a little anoxic, but not very. No. Do I have the carotids? Do I still have the vagus? I think so. There. There is the other vagus, other carotid. And I'm sure that's all right. Now, the trachea. I'll give a little more ether at this moment, because once I've opened the trachea and put in the tracheal cannula, it's a little difficult to anesthetize. So I'll give it a little touch of ether. A little more anesthesia. One of the reasons we have had, I believe, a little trouble with the anesthesia is the fact that it is hot here and the material evaporates more quickly than it would in an ordinary room. But I have inserted the tracheal cannula. I'm now tying it in. So, now we must get things cleaned up to do the rest of the operation. Turn the animal around, just like so. Here is tracheal cannula. I'll put a little ether down here so that by tucking it up around the neck. Let me see now if I can decerebrate this animal quickly. Nope. You know, we're using more ether on this cat than we did on the last horse. And I don't know who's getting more of it, I or the cat. But here now you can see the skull exposed. Here the bone. Now the trephine. Let's take the ether away. Alright. There's the button of bone out. The rongeurs now. Now Arno must compress the vertebrals. Just let go of everything and squeeze that neck as hard as you can. If the animal objects, it's too late, because we must now up a little higher there. There. Now the the spatula. I'll slip this in, cut the brain stem across, scoop out first one hemisphere, second the other hemisphere, and a forceps, a bit of cotton wool. Let go, Arno. And if all has gone well, this animal has been decerebrated. It is breathing. And it is not bleeding greatly in the head. I can now put a string in its head. I need a little knife to make the hole first on both sides. Heavy thread, heavy string. There. There. Okay. Now the stand by which we can hold up its head. And we can start to look at the animal. We turn it around now so that it is lying here. Here is a moment when we stall, because whenever the brain stem is cut, there is a period called spinal shock, and all reflexes disappear for a while, and the animal is relaxed and unresponsive. The only thing that you should watch now is the persistence of breathing. And if you can focus about on my finger, you can see that the animal is breathing. Quietly, but unmistakably. Perhaps by about now, the first reflex will have appeared. Let us turn the animal to look at the camera, lift up one of its legs, and tap its knee. And you see, already it shows a knee jerk. Let's look at the other leg. It too shows the tendon reflex, which is really a very simple form of the myotatic response. If I tap the tendon, this stretches the muscle ever so slightly and invokes just a brief response. So this is the stretch reflex in its simplest form. Now you can see that if instead of tapping just once, I were to push against this leg and try to bend the knee, the reflex would appear, and it does. You can, I think, feel that if even the pressure of the limb itself will hold it straight. I can push it down, overcoming the reflex, and the leg stays down here. I can pick it up, and it stays there. This is the beginning of the myotatic reflex. And if you were here, you could feel the resistance. This resistance has been called the clasp knife response. That is to say, if you were trying to close a clasp knife and trying to fold the blade up on the hinge like I'm trying to fold this leg up at the knee and ankle, there is a resistance produced by the positive myotatic response. If I push too hard, then everything relaxes and the limb comes way down there because of the negative myotatic reflex, a reflex that starts from the tendon organs and prevents excessive, let me see if I can see it. Here, if we can look at the graphic again, we can see the tendon organ that sets up the negative. So here is an intrinsic proprioceptive response that starts with the muscle spindle that creates contraction of the muscle, then a safety valve, you might say, the negative myotatic response that prevents excessive tension. And it is the negative myotatic response that produces the downward movement. Let's look up here in the front. And here too, there is an excellent myotatic response. This animal might just be able to stand by now, and let us see if I can prop it up on its feet. This is sometimes hard because this animal now, can you see the front? This animal is standing pretty well in the front limbs. It is not standing as well in the hind limbs, but it is just barely beginning to stand, most particularly in the front. And if we are lucky and our time holds out, it will stand perfectly well. We should really have had a white cat instead of a black cat for photographic purposes, but I think you can see the beginning of its ability to stand. You notice also there that this animal has no balance. Everything tips over, it its feet. It can't hold its position, but if we prop it up, it can stand. Now, let us stop this for a while and look at just one or two things. First, let's look at the eyes. Can we come right down on the eyes? If we can. See, it still shows a blink reflex. Okay. So, blinks. Can we see its whiskers? Yes, you can see some whiskers down there. If I pinch its ear, the whiskers will come forward. And it can also swallow. Where is my little bottle of swallow juice? This is a secret. And where is my little dropper? As I say, here is the best swallow juice that I have been able to make in the laboratory. Can we see this face? Yes. See its two big front teeth? There's a little water. Did you see the swallow? And not only did it swallow, but what is quite rare, it licked its lips. He deserves another drink for that. His jaws show myotatic reflex, and you see his mouth is held very strongly closed, so I could be bit by a jaw jerk, but there again you saw it swallowing. And if I try to open its jaw, I get the same resistance, the same decerebrate rigidity in the jaw as here. Now that brings us about to the close of the session. You have seen that an animal that has lost the whole of its brainstem anterior to the pons is able to show reflex behavior, is able to stand, and as the time passes and the shock disappears, will stand even better, is able to swallow, is able to respond to stimuli in the eyes and the ears, and therefore shows the rudimentary behavior out of which locomotion, writing, and voluntary activity will develop. Now, next time, we will repeat this observation on an animal that has only about a centimeter more of its brainstem, the hypothalamus, in place. And this is going to cause a remarkable change in its behavior. It will now be able to right itself. It will be able to walk. It will be able to maintain its temperature, and it will no longer be decerebrate. In fact, a decorticate animal, decorticate cat, as I mentioned, will show such an almost complete motor performance that one can hardly tell that the cortex is gone. This brings us to the end of this session, and I will look forward to seeing you next time. Thank you very much.